I'm Randy Wong. I'm a retina specialist in Fairfax, Virginia. And welcome to our monthly webinar on the treatment for floaters. Our website is www.vitrectomyforfloaters.com. And today is August 29th, 2017. Fairfax, Virginia, as many of you know, is about 20 minutes just outside Washington, D.C. I have two websites that you can follow me on at vitrectomyforfloaters.com and Retina Eye Doctor. Let me go back. retinaeyedoctor.com. Bear with me. This webinar is for informational purposes only. This webinar does not offer medical advice, so nothing should be construed as medical advice. The information on this webinar is only offered for informational purposes. You should not act or rely on anything in this webinar or use it as a substitute for medical advice from a licensed professional. The content of this webinar may quickly become outdated, especially due to the nature of the topics covered, which are constantly evolving. The materials and the information on this webinar are not guaranteed to be correct, complete, or timely. Nothing in this webinar and nothing you or I do creates a doctor-patient relationship between you and the webinar, between you and me, or between you and Randall Wong, MD, or retinaeyedoctor.com, or vitrectomyforfloaters.com. Even if you try to contact me through this posting of the webinar or conversations through the webinar, you are not creating a doctor-patient relationship. Although I am a doctor, I am not your doctor until and unless there is a written agreement specifically providing for a doctor-patient relationship. So thank you for bearing with me for the legal verbiage. What I want to do today as kind of a warm-up is just simply talk about normal eye anatomy. And we just have 4 or 5 slides to go through, and this will hopefully help you kind of get an idea of what we're talking about when we are communicating about the eye. I'm going to go from the left or the front of the eye to the back. And in the front is the cornea. That's the clear part that a contact lens rests on. Or if you were to poke yourself in the eye, the cornea is that very clear yet very sensitive tissue that you would first encounter. The next area is the iris, which is the colored part of the eye, and the hole that it creates is the pupil. And just behind that is the lens. And the lens is what can become a cataract as we get older, or as some people claim, after a vitrectomy. The sclera is the white part of the eye. And the ciliary body is very, very hard to imagine, but it is on the inside front of the retina. And the ciliary body makes aqueous fluid, and it also is able to contort the lens so we can see up close. Here's the vitreous, which is the contents. The retina is the lining of the inside of the eye. The macula is the functional center of the retina. It's the only place that gives us 20/20 vision. It gives us our best color perception. It's where all the cones are. The rest of the peripheral retina has all the rods. The optic nerve inserts here. This is where all the nerve endings go and communicate to the brain. And the choroid is one of the deeper layers to the retina. By the way, if you have any questions, just kind of type them up. I should be able to see your questions as we're moving through this. And ideally, maybe I can answer this and answer everything in real time. We've done this before. Okay, so here is the slide we just started. Next is, let's just focus on the retina, which is the inside lining of the eye. It's mistakenly called the back of the eye for reasons I don't quite understand. But as you're looking into the eye, or as you're looking into the room, if you make the analogy that the eye is like a room, The retina is the inside lining of the eye. The retina would be the wallpaper of a room. The functional center of the retina is called the macula, or more specifically, the fovea. But for our purposes, let's just call it the macula. It gives us our reading vision, our best color perception, our ability to see 20/20, etc. This white area here is the optic nerve, and all the axons, or all the nerve endings that constitutes the retina, all travel to this area and then form the optic nerve, which connects the retina to the brain, and that gives us vision. This is a really cool slide because it kind of demonstrates how we see, but what it does for our purposes tonight, it kind of gives you an idea in the vitreous of how floaters can be seen. This yellow trapezoid, or this yellow area, is really light coming in the eye and how it gets focused onto the retina. But what I like it for is that this is what we call the visual axis. And things to the side, above, below, left, and right to the visual axis, can sometimes be seen if they swing into the visual axis, like floaters or vitreous opacities. And this is, this is a slide that is a combination of the normal anatomy, but it has the visual axis highlighted. So you'd see the different parts of the eye, and you also see that this yellow visual axis is really how we see. Anything that swings or gets in the way of the visual axis can decrease the vision, such as vitreous opacities or floaters. So I'd like to limit this to about 30 minutes if we can. Go ahead and ask questions by typing in the chat section. Ask me about anatomy, ask me anything you want, and we'll just get started. Thanks everybody for coming. This is really amazing. There's so many people from out of the country that are joining tonight. So, Chrissy, I think maybe we picked the right time tonight. If you got questions, just go ahead and type it in the chat section. Or if you don't, then Scott asks, oh, here we go. Scott asks, how do contacts affect the procedure? Well, I'm going to go back on this slide here. Let's look at this first slide. Contact lenses rest on the cornea, or on the outside of the eye. So they have absolutely no relevance to having a vitrectomy done. They have no relevance to causing or improving upon floaters. So basically, contacts don't enter into the equation. Sandro asks, I had an onset of many large floaters in both eyes as well as rapid change in vision, potentially a result of bacterial infection that I contracted while living in Asia. What are other possible causes of an onset of floaters in both eyes as well as a major overnight vision change? I'm going to have to break that down because I'm not so sure that anything is coming to mind to answer. Is there one event which causes lots of floaters and a huge overnight vision change? And what I'm thinking you're saying is that your vision changed, your refraction changed. I mean, you could have floaters from a vitreous hemorrhage, which would decrease your vision, and that could happen overnight. But obviously, I don't think that happened. Floaters generally can happen after a PVD, posterior vitreous detachment. They can happen after a vitreous hemorrhage. Those are probably the two quickest ways to get new onset floaters. Major overnight vision change, I think you'd have to define that better. It could be to blood. That could probably be the only thing. I mean, obviously, if you had a retinal detachment, your vision would change quickly, but I think you would have stated it a different way. Sorry. Eric asks, what is primary floaters? Eric, I'm going to ask you to re-ask that question because I don't know what that means. Actually, never heard that term before, primary floaters. Chris says, what would you say the average recovery time after FOV to be able to regain full 20/20 if it is needed to return to work? I'm going to generally say, in many cases, about a week. If what you're saying is you need to be back to 20/20 before you can get back to work, I would say a week, maybe two at most. I would say most people tend to regain most, if not all, of the vision very quickly within 3, 4, 5 days. Everyone's different, of course. Scott says, once you've had the procedure, are you able to get new floaters? The technical answer to that is yes, you could, because you could have bleeding for some reason. But I think what you're really asking is, could the same situation recur? And the answer is no. Most of your vitreous is gone. That's where the culprit is. So I don't think that you're going to get a recurrence of floaters. Other causes of floaters, not truly germane to this, are vitreous hemorrhage. You could get a vitreous hemorrhage for some reason. And if you have a history of uveitis or iritis or inflammation inside the eye that can cause floaters, that in theory is possible. But for what we're talking about, it's highly unlikely this is going to recur. Eric says, for patients who have recently went through photocoagulation for maybe half a year to say 3 months, are they suitable for FOV? And the answer is yes. It probably doesn't really relate. I'm curious as to why you needed photocoagulation. Maybe it was for a tear in the retina, or maybe for treatment for diabetic retinopathy or some type of retinal vascular occlusion. But that should not preclude you from having a vitrectomy if you have floaters which are really bothering you. Oh, for atrophic holes. Eric, that should not, I personally don't think that precludes you in any way. It's common that patients who have atrophic holes in the retina need laser treatment so that they do not get a retinal detachment from those particular holes. And having laser treatment does not mean that you cannot have a vitrectomy or an FOV. How many of FOVs do I perform in, say, a year? Let's say if I change that to how many vitrectomies do I perform in a year, several hundred at least. Vitrectomy is the core operation that a retina surgeon does, and we probably do anywhere from 500 to 1,000 a year. Not strictly just FOVs, but for all cases. And I quite honestly don't have the data at hand to tell you how many are just for vitreous opacities versus vitrectomies for other causes. Chris says, is there a certain time window post-FOV where retinal detachments is at a high risk of occurrence? I'm going to say yes. It's probably somewhere, you're not going to like the answer, but it's probably somewhere between the first 4 to 6 weeks and then the next 6 to 12 weeks. And then it's probably the chance of you getting a retinal detachment from the surgery probably drops dramatically. That is to say, I think if you were to have a retinal detachment, it's going to occur within that window. I generally am probably most concerned within the first 6 weeks, but nothing would surprise me. Chrissy, is there anything you would want me to mention? Chris says, is there a certain time window? Not sure what you mean, but is there a certain time window where a retinal detachment could occur? Or is it in relation to your previous question about when you could return to work? I generally think if you're worried about retinal detachment, it's probably going to occur within the first 6 weeks or so. Sandra says, my floaters are particularly large, of various shapes and sizes. However, some of my ophthalmologists have told me they don't notice as much as I describe. That's common, by the way. I'm 26 and my floaters came all at once, and according to my ophthalmologist, my retina looks okay. Also very common. Is there a reason doctors may overlook floaters in younger patients? Actually, I don't think that either side is at fault. It is more likely that you are like many other young patients that have floaters in both eyes, and it's very hard for we doctors to see them. As I've been over the last 5, 7, 8 years, as I've been, as many young patients as many young people become my patients, I've noticed that there's a correlation between young people that complain of floaters. They usually have complaints in both eyes, and it is quite common that they tell me their doctors can't see anything, and even when I look, I don't see much. What I can tell you happily is that almost all of them after, if not all of them, after vitrectomy, they're doing quite well in terms of having a significant reduction in floaters. I'm going to go back to this slide here. So remember that the vitreous fills the eye, and there is only one place where floaters can occur. And if we define floaters as something that moves to and fro with eye movement, those opacities can only be located in the vitreous. So if you are aware that by moving your eyes you can get these floaters or opacities to move, then the opacities have to be in the vitreous, because there's nowhere else in the anatomy of the eye where a spot or floaters can move with eye movement. And therefore, if that's true, vitrectomy or FOV should be very, very helpful. Scott says, do you do FOV on both eyes at the same visit? Nope. I prefer to wait several weeks. Actually, if we can, wait several months if we're going to operate on the other eye. I would hate to have complications in two eyes, because although it's extremely unusual and rare, I'd hate to have that occur. And there's no rush. Once we do one, you're better, and at some point, we can agree to do your second eye. Eric says, we'll use some kind of ultrasound or CT to determine the position and numbers of patients with floaters, so to determine the best treatment for floater sufferers. No, I don't use OCT at all or ultrasound. I have been very successful just looking straight at your eye and talking to you, and removing the vitreous is highly efficient at getting rid of the floaters that are bothering you. Chrissy asks you to email her about insurance questions. A lot of insurances, most, if not all, do cover FOV. There is some concern about international coverage, of course, but she would like to tell you that she would like to help guide you through the basics. Medicare in the U.S. does cover it. She can also assist with self-pay rates if insurance isn't an option. And here's her email address, rwong13@gmail.com. So I'm going to switch to that slide. Here's Chrissy's contact information, rwongcm13@gmail.com. email about insurance information. She'll also tell you about what we need about drivers, although I think we found a nice workaround, but I don't want to say it publicly yet. She'll help you with scheduling surgery and talk about medical clearance. That's me, my daughter, and two of my kids. I'd like to thank Mark Erickson. He is the one that gives me all our ophthalmic images. He is probably the best ophthalmic illustrator on the planet. Chris says, do you foresee 27 gauge having any near future improvements in the surgery? The answer to that is not really. The only advantage I see with 27 gauge right now is that it's slightly smaller holes, but especially for outer towners, I prefer to close the 25 gauge holes with sutures. I think the 27 gauge is going to add time to the surgery because the holes are smaller, and I don't think that 27 gauge is going to be as significant an improvement as 25 gauge was to 20 gauge, if that doesn't confuse you. Sandro says, in the case of younger patients, how might they be treated different, especially in relation to inducing PVD, or is there more or less no difference in treatment according to the age of the patient? There's really no difference, although in patients without a PVD, I would have a nice discussion as to why we should induce a PVD. Scott says, when traveling there, can you walk through a normal procedure? How many days, etc.? Scott, where are you from? Going back. Michigan. So what commonly happens is patients will call Chrissy or call Ashley, schedule an appointment, and schedule surgery. Surgery for you would be on a Friday. I would see you on a Wednesday or Thursday. We would go over the examination, have a discussion, and if we agree that we can do surgery, then you stay for surgery, which will be performed Friday. I will see you Saturday, and in almost every case, then you are free to go. What I would like you to do before you come to town, however, is make sure that you have your own doctor that's willing to examine you 7 to 10 days after surgery. And that way I can make sure that you're getting appropriate follow-up, and I can communicate with that doctor as to the things that I think are important to your post-operative care. So the answer to your question is probably 2 to 3 days. You'd come in on a Thursday, I'd see you, we operate Friday, stay one more night, and you can take off Saturday after I see you. Chrissy says that she can email you a step-by-step guide that explains everything. Thanks, Scott. They're kind of crazy. My daughter's now 26. That's me when I thought crew cuts were cool. And these two little guys are now 19 years old. And this was taken, I think, when they were about 7 or 8. So it was a while ago. I haven't aged, of course, at all. Yes, time does fly. How about 1 or 2 last questions? Otherwise, we're going to call it a night. The U.S. Open is on, and I think my favorite player in the whole world, Roger Federer, is going to play, in case any of you are tennis fans. Christine, any last words? Well, listen, everybody, thanks so much for taking time to participate in the webinar. I will put this up probably tonight or tomorrow on YouTube. I missed the question. Eric asks, I know you now induce a PVD, which is inconsistent with the manner you used before, so I might ask Dr. Wong, what changed your manner in FOV? What really changed my mind is the number is the young patients that obsessed about frill. And I've also been doing this long enough so that if we don't induce a PVD and then you get one, then that can be just as problematic. Operating on an eye with a PVD is probably the most efficient way I can remove most of the vitreous. I can do it efficiently, meaning I can reduce a greater amount and I can do it quickly, reducing operating time, reducing the chance for complications, reducing the chance of frill. So those are all the reasons that I've really changed my opinion. That's a great question. Well, listen, everybody, I'm Randy Wong. Thank you so much for joining me. You know our website addresses, retinaeyedoctor.com or vitrectomyforfloaters.com. Contact Chrissy if you have any logistic questions. You can email us if you have questions that you forgot to ask tonight. Chrissy's email is rwongcm13@gmail.com. Sandra says, thanks a lot, Dr. Wong and Chrissy, for the info and the great work. See you in October. No pun intended. Look forward to seeing you too. Chrissy, thanks for joining. You're always such a great help. Chris says, many thanks to both of you for taking the time to do this. You're very welcome. If we can be of further service, let us know. And if you'd like to join us next month, love to see you. Good night, everybody.